To start with, microphakia. Microphakia is a small lens here, but not spherical. You have to differentiate between microphakia and lamellar cataract during surgery. Here, this is a lamellar cataract and not microphakia, and here you can see that the lens are in normal place, and here after conventional cataract surgery. However, in cases of microphakia, as in this case, still we go as a conventional surgery. We go for the anterior capsulorhexis and posterior capsulorhexis together with anterior vitrectomy, and finally close the wound as if we are performing a straightforward pediatric cataract surgery. And in cases in microphakia, when we want to implant, we still can implant as long as it is not a microspherophakia. And in these cases, again, we go for the anterior and posterior rhexis, and we can inject the IOL inside the bag. And you can see here, this is the equator of the lens, and these are the dominoes. However, a microspherophakia is another thing. This is considered as a pediatric ocular emergency. It is variable in sizes. We can see different sizes of microspherophakia. It can be central or slightly eccentric in the pupillary area. And usually, children present with a shallow anterior chamber, tremulous iris, large corneal diameter. This large corneal diameter, either it is a megalocornea or it is associated with a congenital glaucoma. This is the corneal diameter is large due to association of congenital glaucoma. It may be associated with a spherical cornea. I'm sorry, لأن الصورة مشدودة. Or maybe associated with elliptical shape like that of the cornea. An edge of, glistening edge of the lens may be seen at the side of the pupil here, or a glistening circumferential glistening edge is seen with a totally dilated pupil. It is usually associated with very high myopia reaching over -20 due to the high spherical appearance of the lens, and usually associated with very high astigmatism due to subluxation of the microspherophakia reaching, for example, here -11, which is not amenable to be corrected by spectacles. It may be associated with syndromes as Weimar-Kisani syndrome. They usually short stature, as we see. This is a child 7-year-old, and here his sister 10 years old, associated with small square hands and small square feet. And in Weimar-Kisani also, apart from the small square hands and the small square feet, as in this child, it is associated with short stature, also can be associated with premorbid obesity and endocrinal anomalies. Why it is considered as an ocular emergency in children? Because it easily pops into the anterior chamber like that, damaging the back surface of the cornea, and sometimes being like that in the anterior chamber that become cataractus. And here we see that the lens, even adherent to the back surface, become adherent to the back surface of the cornea, or it may dislocate into the posterior segment. And in other patients, as in this child, it is present in the anterior chamber, and then when lying down, it pops into the posterior chamber like that, and in and out into the anterior chamber and back again to the posterior chamber, may lead to retinal detachment, as you see here, the lens associated with pigments in the vitreous Scheffer's sign, indicating the presence of retinal tear and a start of PVR. It may be associated with many forms of glaucoma, as congenital glaucoma, as we see here, or associated with acquired glaucoma, as in this child, due to secondary angle closure glaucoma, that sometimes it is very severe, that the iris become adherent to the back surface of the cornea. There is a form of iridocorneal contact. Another form of glaucoma, as in this child, may be associated with pupillary block glaucoma, and sometimes this pupillary block glaucoma is so severe, associated with severe corneal edema. And here, a form of long-standing pupillary block glaucoma associated with extensive patches of iris atrophy. And another child presenting with very long-standing pupillary block glaucoma, as we see here, associated even with ciliary staphyloma. Another patient presenting with keratolenticulaire adhesion, iridocorneal adhesion, total loss of the anterior chamber, pupillary block together with angle closure glaucoma. As we know that the congenital aniridia may present with a clear lens or a cataractous lens, but the shape of the lens is somewhat normal. But in some cases of congenital aniridia may be associated with microspherophakia, increasing the risk of secondary glaucoma, and even cases with microspherophakia and aniridia may be associated with keratolenticulaire adhesion, and another eye here presenting with a keratolenticulaire adhesion and secondary glaucoma. So all types of glaucoma may be associated with microspherophakia. Once we diagnose microspherophakia, it is considered for surgery immediately, once diagnosed, before proceeding to blinding complications. We can go for surgery, and it's a very simple surgery through 2 corneal wounds using MVR knife 20 gauge, that is 0.9 millimeter. And then we make a tear in the anterior chamber using a cystotome, small tear like that, and then we go forward with a microrhexis forceps 23 or 25 gauge. We perform anterior capsulorhexis, and then we hook the anterior capsulorhexis by means of a hook and an iris retractor in order to stabilize the lens, and then we go for a hydrodissection, irrigation aspiration, and finally the capsular bag, the left capsular bag is eaten up with a cutter, perform anterior vitrectomy, and finally these 2 small wounds are sutured each by 1 suture. However, sometimes there are difficulties during surgery. Sometimes when you go for tearing the anterior capsule in these microspherophakic eyes, it is very tough and very difficult to tear. So what to do? With a special forceps, we grasp the anterior capsule and then cut with micro scissors the anterior capsule, and then proceed with the anterior capsulorhexis in the conventional way. And sometimes when we hook the anterior capsulorhexis with the iris retractor, it is not that always that easy. Sometimes the lens is so small and it is away from the hook. We cannot reach the edge of the rhexis by the hook. And in these cases, we use a Y-shaped spatula in order to push the anterior rhexis towards the hook, facilitating this iris hook to the lens. You may say, why all these steps? You go in and eat up the lens immediately with a cutter. However, there are advantages of this hooking of the anterior capsulorhexis. Number one, it makes a sort of a tent here. Introducing the cannula with the irrigation, you may perform a perfect hydrodissection. Perfect hydrodissection will actually facilitate the irrigation aspiration, going to be very easy, and it's going to take seconds. And once you are inside the capsular bag, you're not out until you finish irrigation aspiration. Going to be easy later on to have a beautiful capsular bag. You can eat it easily with a cutter and perform the anterior vitrectomy very easy. Another advantage of this iris hook is that, can you see here, before irrigation aspiration, the zonules are there. When you go for hooking of the capsule, and then you go for irrigation aspiration, after irrigation aspiration, the zonules are still there, indicating that there is no prolapse during irrigation aspiration of the anterior vitreous space, indicating that the anterior vitreous space, you don't disrupt it. Excessive fluctuation of the anterior chamber and disruption of the anterior vitreous space may predispose to retinal detachment and retinal tears later on in the future. Look here, this is before irrigation aspiration, and after irrigation aspiration, the zonules are the same. And again, you eat up the capsular bag, perform the vitrectomy, and finish the surgery. Here an eye before the surgery with shallow anterior chamber, and here immediately after surgery with deep anterior chamber, and then we fit the children immediately with the aphakic spectacles. This is another example of a child with bilateral microspherophakia. One eye dislocated into the anterior chamber and the other is subluxated, here immediately after surgery. In these children, we can implant iris glow lens as a secondary procedure in the anterior chamber, and here immediately after surgery, few weeks after surgery, and an eye few years after surgery. Or we may implant the iris glow lens into the posterior segment, into the posterior chamber, and here we can see the enclavation of the iris from the back surface of the iris. This is another example of a child implanted with anterior chamber iris glow lens in one eye and a posterior chamber in the other. This is another example of a child that was misdiagnosed as primary congenital glaucoma and was treated since birth as a primary congenital glaucoma, and she had 4 failed surgery. And always they say that there was a failure to reform the anterior chamber because the diagnosis was wrong. She had here a trabeculectomy in both eyes, a large iridectomy. Actually, this is not a primary congenital glaucoma, this is a secondary congenital glaucoma to microspherophakia. So the treatment from the start was not to start by the glaucoma, but to start by lensectomy. So immediately we performed her lensectomy, here the microspherophakia, irrigation aspiration. This is the small capsular bag, eaten up with a cutter, performing anterior vitrectomy, and finally closure of these tiny ones before proceeding with the glaucoma again. This is another example with microspherophakia, cataractis, pupillary block, and there is adhesion between the cornea and the iris and the cornea. It was very difficult during surgery even to refill the anterior chamber with a viscoelastic. It goes out. However, we had to go for irrigation aspiration and anterior vitrectomy and clearing all the adhesions between the iris and the cornea before proceeding with the glaucoma. Finally, this is an example of a child with a long-standing papillary blood glaucoma, here before and at the start of surgery and at conclusion of surgery, immediately after surgery, and here before and few months after surgery. Vision was preserved in the right eye and glaucoma was controlled in the left eye. And of course, we had to go for screening of the other sibling. We diagnosed her brother as having a microspherophakia, and it was possible to perform lensectomy and preserve the eye and preserve vision and preventing other complications. We have to go for very long-term follow-up in these patients, as in this child here immediately after surgery and 10 years after surgery. Why? Because glaucoma may occur years and years after surgery. Finally, to conclude, microspherophakia may present with a high myopia, high astigmatism, blinding complications as anterior and posterior dislocation of the lens into the posterior segment, and of course, many forms of congenital glaucoma or acquired glaucoma. And since, owing to these serious complications, it is considered as one of the pediatric ocular emergencies that have to be dealt with immediately with lensectomy. And thank you very much for your kind attention.